Yeah. So with that, I want to just, again, this is meant to be interactive session. So I'll just show you a few, CGM traces, and then we can talk and interact as to what would be the most optimum therapy. So again, this is an example of CGM report in a normal, healthy subject. So as Dr. Unnikrishnan mentioned in his talk, very tightly controlled glucose, as you can see. So, this is a normal subject, healthy subject, very tightly controlled glucose. But if you look at the interquartile ranges, even in a healthy subject, there is biochemical hypoglycemia, but obviously he's healthy. So this is normal physiology. Now, so one of the concepts are, if the human body spends so much energy to maintain blood glucose levels within such a narrow range, it is because otherwise it would be harmful. So again, clearly, the goal is eventually for all our patients with diabetes to try and restore normal glucose as far as possible without causing hypoglycemia. That's the challenge. So let's look at a few cases. Now, here is a patient with an hemoglobin A1C of 8.1%, and this is the CGM trace. So anyone wants to volunteer as to what are the abnormalities here? Yes, sir. So as he pointed out quite rightly, although the median value is okay, there's large variability overnight also, and it tends to rise, early in the morning, post-breakfast and through lunch, but post-dinner, it's not bad. So what did they do? So they decreased the basal and adjusted timing and adjusted bolus. The A1C has come down to 7.5%, or the estimated A1C. But how would you interpret this CGM data in the same patient after making some adjustments? So again, there's no right answer, but this is what happened. The second interventional AGP looks even worse than the baseline one. So, after decreasing the basal, the blood sugars went up overnight. And although the daytime variability and the daytime rises in blood sugars also, didn't improve much. So what did the doctor do? Increase basal again. So again, there's no right answer, but the CGM can help in the interpretation and in the management of these patients over time. You cannot expect to hit the magic number straight with the first time dose adjustments. The third interventional AGP, again, this looks better, but there's a huge variability post-breakfast. So they adjusted the bolus, adjusted the insulin carb ratio for the bolus, and adjusted the meal content. One of my favorite things to tell my students is that if you have patients with diabetes stop eating, diabetes will not be a problem anymore. But we have to eat to live, to survive. So again, if you see that with all these iterations, compared to the first baseline CGM to the fourth interventional CGM, there has been some improvement, but still there are these spikes that are happening with meals. So again, these CGM examples are there to illustrate that CGM can help in management of these patients, probably more than finger stick glucoses. Usually the first thing we look at, or first thing we want to improve in a patient with diabetes who's taking insulin is overnight blood sugars. We want to concentrate on the overnight blood sugars to prevent hypoglycemia, because nocturnal hypoglycemia can be dangerous if the patient is asleep, because what hypoglycemia does physiologically is that it prolongs the QT interval of the ECG, of the cardiac electrical circuit. And prolonging the QT interval will increase the risk of ventricular tachyarrhythmias. So you want to prevent hypoglycemia, especially at night when the patient is asleep. So again, that is very important. So in this patient, there is although there is large glucose variability, there is no clear hypoglycemia, but the blood sugars are tending to rise. So in this case, what the doctor did was to change the basal insulin as a single dose in the morning to split AM and PM and adjusted the bolus dosages as well. And this is what happened. So basically, the variability reduced overnight, but there was still a tendency for blood sugars to rise post-breakfast. So then the next step was that they adjusted the AM basal because the variability was still high, tending to rise as the night progressed, and they adjusted the AM bolus. With that, things became better. And the overall glucose variability and the median blood sugars were not too bad after making these adjustments. Subsequently, again, these are our patients that were studied many years ago. As you can see, with further changes to insulin regimen, compared to the baseline AGP, the 7th interventional AGP looked better overall. So again, we also need to remember that, yes, although we want to try and restore blood sugars to normal in patients who are taking insulin, it is not physiological. We are giving the insulin into the subcutaneous tissue. So it's going to the systemic circulation versus in the normal human being where the insulin goes into the portal circulation. Hence, the regulation of blood glucose and carbohydrate metabolism is much better when insulin is delivered directly to the liver than if it has to go to the subcutaneous tissue into the systemic circulation. Okay, so this is someone who is on metformin, sitagliptin, and gliclazide, so a type 2 diabetic versus the previous patients who are on insulin therapy. So this was the baseline AGP on this patient with an A1C of 10.2%. Anyone from this side of the aisle wants to interpret this? Any volunteers? Otherwise, we'll pick one.
Dr. Sontake, can you interpret this?
Friendly audience, we're just sharing.
Yeah, there's no right answer. There's no right answer. So first, how would you interpret this? Yes.
This patient has got fairly high sugars, median sugar is high, but he has got postprandial peaks at both the lunch and dinner. Peak.
Okay.
What would you like to do?
Versus what was done. Do you agree with what the doctors did there? They halted the gliclazide or the glimepiride and the DPP-4 and started once weekly GLP-1 receptor agonist. Do you agree with that? As I said, there's no right answer. What would you have done if you had seen this patient?
I would have increased the basal dose and or also adjusted the boluses.
Now, remember, this patient was, if you want to go back, this patient was on metformin, sitagliptin, and gliclazide. This patient is not on insulin when this AGP was done. Alpha glucosidase, and why do you say, sir? Okay, postprandial, but how about the overnight glucose? The overnight glucose is also very high. As you can see, this is midnight, and then, till 6 a.m., the blood sugars are falling slowly, but they're still very high.
If I know the weight of the patient and the duration of diabetes and presence of, the complications, whether the nephropathy is there or not, then I would actually up-titrate the dose of metformin and DPP.
So you want to, so again, this is, BMI is 32, so he is mildly obese. So you wanted to go up on the metformin. Now, let's say the metformin dose was at the maximum, 2 grams a day. And sitagliptin is 100 milligrams a day. Okay. What would you do?
Sir, long-acting insulin with GLP-1 RA.
So you want to start
continuing DPP-4.
You want to start 2 medications at the same time?
Yes, sir.
And stop?
SUs to be stopped, continued with DPP-4 and
okay.
metformin.
So I think the doctor, to some extent, agreed with.
Who doesn't agree?
Fair enough. We'll see what happened and what happened after this doctor halted the sulfonylurea and the sitagliptin, continued on the metformin, and started once weekly GLP-1 receptor agonist. So this is what happened. The top one is metformin and GLP-1 receptor agonist. So just concentrate on the top part of the AGP. Who wants to interpret this? Did things improve at all?
Yeah, fantastic improvement.
So you say it's improved tremendously. Someone in the back said no, things didn't change. So why do you say it's improved, sir?
Overall exposure has come down. Variability has come down.
Variability has come down.
The risk of hypoglycemia is much less.
Sorry, the risk of?
Even hypoglycemia is less.
Right,
Your HbA1c is, estimated HbA1c is less.
right.
It's better definitely.
So things have improved. No
what
question.
else we want?
No.
Do you think, so if I asked, I know there are different opinions here.
So this
but
is what was previous.
This is previous. So yes, it's better than previous. But now look at top panel versus the bottom panel. Look at the top. Where are the blood sugars ranging?
It is still high overnight.
Still very high.
So it's better compared to the first one, but we're not there yet. Obviously, we are not there yet. So based on this, then what the doctor did was started basal insulin. And look what happened after that. Dream come true. So basically, you know, could you have done this even without the use of CGM? Probably, but then the patient would have had to do, you know, self-monitoring of blood glucose 6, 7, 8 times a day, and that is expensive. And then again, you would not know necessarily what happens overnight because you cannot expect the patient to wake up every 2 to 3 hours overnight to check their finger stick glucose. So certainly, you know, the duration of the journey was shortened by using these diagnostic CGMs. Comments?
Why would it take 6 months to reach this control?
Very good question. Why would you take 6 months to reach? You know,
All the
again,
technology with everything
yes.
available.
So basically, you know, you have touched upon a very important point. Yes, CGMs are getting better, no question. And the newer CGMs from, you know, the Abbott, Dexcom, et cetera, do not need calibration. It's factory calibrated. But affordability is number one. You know, the patients need to afford a CGM. So not all, you know, insurance covers every CGM. And you would be, you know, it's important to know that even in patients with established type 1 diabetes for 30, 40 years in the US, you have to do a C-peptide and a concomitant glucose so that the insurance company would approve, you know, the use of a CGM. You have to show, even clinically, it looks like a duck, it feels like a duck, it quacks like a duck. But for insurance coverage, you have to measure C-peptide to convince insurance, that they will cover a CGM. So again, so it took 6 months due to various reasons. You know, the patient cannot come back frequently to get this done, the expenses involved, insurance coverage, and so on and so forth. Things are getting better, no question. You know, recently the Medicare and Medicaid services in the US have approved the use of CGM in selected patients, but we still have a long way to go. So yes, I mean, in a patient who can use their own money to buy CGMs, this would have been much quicker.
And
Right.
actually it is so painful for SMBG, say 6 or 7 times a day.
Right.
It is much convenient for the patient.
Absolutely.
And we would do it much faster because here, especially one CGM is much cheaper and though it is not time related, it's
Yeah,
easier for us
Correct.
actually.
And remember the
And
CGM
it's affordable. Bus, $20.
for the, okay, for one of the CGMs.
Yeah.
Right, right. But I mean, the thing is, you know, so it is much better in this country than we have in the US, at least for, you know, for most of the CGMs. So you are fortunate. So certainly use the CGMs. Yes, sir.
So,
You think we're not trying? we are trying, definitely. You know, we have tried, and they are getting better, but wherever it involves money, you know, other things play an important role.
Sir,
Yes, sir.
here we have done the changes in medication at the end of each sensor readings. at the end of 14 days.
Correct.
So can we optimize the medications on day-to-day basis rather than at the end of 14 days?
That's a very good question. Now, when people looked at the data, they came to the conclusion, again, there have not been any randomized controlled trials to look at that, but generally speaking, for most patients who are especially on insulin, you require at least 2 weeks of CGM data to look at the patterns, okay, to look at definitive patterns of the CGM before you're advised to make changes. Again, it depends from patient to patient. Because we did these studies some years ago when we were at Mayo Clinic, we looked at the day-to-day variability over 3 or 4 days of glucose patterns in patients with type 1 diabetes versus matched non-diabetic controls. The variability of glucose in patients with type 1 diabetes on insulin pump was 4-fold higher. We do not know why. As I said, it could be because we are giving the insulin into the subcutaneous tissue, it's going through the systemic circulation versus the portal circulation. But even when we fixed the activity and we gave these patients with diabetes the same meal 3 times a day at the same time, we restricted their physical activity, we measured their physical activity with accelerometers, and we've strictly clamped their physical activity, we clamped their meal, that they ate the same meal 3 times a day for 3 days. Non-diabetics, 20 subjects, type 1 diabetes, about 25 subjects. We published this a few years ago. The variability in a type 1 diabetic is 4 to 5-fold higher. So we do not know why that is. We looked at various hormones, cortisol, melatonin, growth hormone. We didn't come up with an answer. So, because of the variability, you cannot really change insulin dose based on just one pattern, 1 day's pattern of CGM. You have to wait for a while to make it safe. And again, there's really no hurry in getting the blood sugars to a safe range unless they're getting severe hypoglycemia. Short-term hyperglycemia has not been shown to cause any damage to the microvasculature or the macrovasculature. It's the long-term glucose exposure that matters. So if you make too frequent, too rapid changes, it'll be difficult for you to interpret because any change will take some time to adjust on a particular human being, on a particular diabetic. So Mark is a 53-year-old former lawyer, okay? So you have to be very careful in the US, who developed a type 1 diabetes at age 29, history of problematic hypoglycemia as a result of aggressive insulin use in an effort to keep his hemoglobin A1C in the non-diabetic range. Now, this is also very important that I see frequently in patients. For example, a year ago, I saw a patient with type 1 diabetes who was on the insulin pump, and he was a NASA engineer, so he is all about data. So with his insulin pump, he had 48 different basal rates in a 24-hour period. Incredible. So I didn't want to make any changes. I said, you're doing great. 48 different basal rates in a 24-hour period. But anyway, so technology is very important, but when used appropriately. So let's go ahead. Numerous episodes of severe hypoglycemia and loss of hypoglycemic warning symptom with a very high gold score. So his most recent hemoglobin A1C was 6.4%, measured 3 months ago. And he generally runs between 5.8, so very tight control. And currently on Lantus insulin, 18 units in bedtime, and insulin analogs, 20 units a day with meals, varies with meals. So anyone wants to help in the interpretation of the CGM, as shown in the top half. What do you see? कोई सामने आ जाओ. Phone, my microphone.
So one, I think the AGP is showing that it's not a nice serpentine thing, so there's a lot of day-to-day variability. The shaded portions are showing you that there's a lot of behavior-related issues when you see that kind of fluctuation. So the patient is either snacking, eating, or changing the dose. you're of course seeing some readings in the hypoglycemic range in the nocturnal period, post-breakfast, and multiple spikes, but largely a lot of variability through the day and some patient-related behavior which needs to be looked into in those shaded zones.
Absolutely. And as I said, there's lots of hypoglycemia, especially at night. And that, as we discussed, is dangerous because it prolongs the QT interval and chances of cardiac arrhythmias. So let's see what this physician did. So first intervention after 2 weeks of reduced evening basal. So they reduced the basal insulin, I think, from 18 units down. What happened? So the interpretation was 20% of time his blood sugar was below 70, mainly due to corrective short-acting boluses at bedtime with high daytime glucose variability. So yes, the reduced basal certainly reduced the hypoglycemia, but there was still a lot of variability because this patient, being very active in their own management of diabetes, was doing a lot of correction boluses. And that is something that, as we all know, can be dangerous because if you correct too often, there's a risk of stacking of insulin. So that even before the first dose effects of insulin are gone, you're adding a second dose and a third dose, so stacking occurs, and that increases the glucose variability. So, second intervention, after 2 weeks on the same basal dose with no corrections post-dinner, things are looking better during the day. They're still up and down, but the variability seems to be less. Again, the A1C, or the estimated A1C, has not changed much. Now, after 2 weeks of minimizing correction, things are a lot better. Now, obviously, the patient also is very involved in his care. He increased his meal bolus sizes as he didn't feel comfortable not to correct otherwise. So again, as we discussed before, behavioral changes are very difficult, especially if a person, if a diabetic who is actively involved, wants to get his blood sugars within the normal range 24/7 is going to be very difficult. And you have to work with the patient to gradually change behaviors that will improve glucose control throughout the time. So again, there's no right answer. You have to work with the patient, help him understand his carbohydrate physiology, because no two patients with type 1 diabetes, or for that matter with type 2 diabetes, are the same. James is a male, 60 years of age with type 1 diabetes on multiple daily injections of insulin. Insulin basal is 20 units per day at night, bolus 7 units 3 times a day before meals. 6 to 7 times he checks his blood sugars. Erratic hemoglobin A1C ranging from 6 to 7.5%. Anyone wants to interpret this?
Or what should we do next?
Or what should we do next? Should we do anything? The night dose is okay. The basal dose is okay. But there's some daytime glucose variability, especially post-lunch. So again, this illustrates one of the things that is very important, that there is a diurnal pattern of insulin action. Insulin sensitivity can change with meals. There is a circadian pattern, which is just opposite to a non-diabetic. And we published this some years back, that in patients with type 1 diabetes, mostly reasonably well controlled with an A1C averaging around 7.5 to 8%, the insulin sensitivity actually improves as the day progresses. The post-breakfast insulin resistance is highest. Post-lunch and post-dinner is lower. It's just the opposite to healthy individuals. In healthy individuals who are not diabetic, the best insulin sensitivity is at breakfast time. And as the day progresses, insulin sensitivity actually worsens. While in the type 1 diabetic, it's just the opposite. Again, we do not know why. It could be that if these patients with type 1 diabetes, because they may be hyperglycemic overnight, that can cause a bit of glucose toxicity, and hence the post-breakfast insulin sensitivity is the worst. So having the same insulin carb ratio for breakfast, lunch, and dinner may not work for every patient with type 1 diabetes. You know, you may need to adjust the insulin carb ratio for breakfast, lunch, and dinner individually based on glucose patterns. So just taking blindly 7 units or what have you of short, mealtime insulin 3 times a day may not be enough. You may need to educate the patient based on CGM profiles so that they can adjust the insulin carb ratios appropriately. Comments?
Another thing is when the variability is high, that means the inter-day variability, wouldn't it be nice to even look at the daily glucose profiles when you're trying to interpret the average ambulatory glucose profile?
It can be helpful, absolutely. For example, patients who are working night shifts, for example, or patients working during weekends. Again, daily patterns are helpful, no question about it. I'm not disregarding the daily patterns at all. But so every patient is unique, is different. So you have to look at the daily patterns absolutely to see whether you can recognize that weekends may be entirely different than weekdays.
Yes.
Or patients working evening shift or night shift will be entirely different. And again, these studies need to be done to see whether the circadian pattern of insulin sensitivity changes in night shifts or in nurses who are working at night. So again, these studies need to be done. We don't know everything.
Dr. Basu, this patient, the lawyer, who was very keen to keep it normal 24/7, does such patient go for some psychological counseling in US?
Behavioral, yes.
Yeah, behavioral therapy, you may say.
Yes, and that is one of the things.
Here we are the psychologists of the patient.
Yeah, of course, of course. But then again, at the University of Virginia, I'm trying to integrate this so that, when a patient is seen by the endocrinologist, if the endocrinologist feels that the patient needs behavioral care or what have you, we can arrange these appointments to happen straight away, the same day or the next day, so the patient doesn't have to come back a month or 2 months later to change behaviors. So it's a challenge, no question about it. It's not a perfect world.
Yeah, Manan.
Yes. Again, these cases, I want more interaction.
It's not about the cases. It's more about, the insulin to carb ratio. A while back, there was also talks on not only insulin to carb ratio, but insulin to
fat
ratio.
Yes.
Now, in a Western diet, I can understand in the Indian Asian diet, insulin to carb ratio is good.
Correct.
This is also a fault of, maybe this person is not having much of carbs and hence has kept 7/7, but it's actually the fat which is changing from meal to meal. And
no question. And this insulin carb ratio is really an oversimplification. Nobody eats only carbs. And we also know that fats and protein changes insulin sensitivity, changes gastric emptying. So again, these are challenges that need to be worked out. Ideally, we probably need an insulin to carb fat protein ratio. Again, those studies need to be done. We are concentrating too much on carbs.
also, one other comment is on the estimated A1C.
Yes.
I'm sure you have a huge amount of work, but here in certain patients' data that we've been seeing, actually we're trying to bring down the importance of the estimated A1C.
Correct.
We've just submitted a paper which has been accepted at ADA, where we tried to show that the estimated A1C based on this is not something that we should be dwelling on because it's misguiding us more often
Exactly.
than-
Absolutely. I was going to come to that. Estimated A1C is a mathematical calculation, and human body is not mathematics. There is some mathematics, but not all. Yeah.
We look at the profiles. That's what's
Yes,
important here.
yeah.
We don't actually, at least for us, we don't pay
Where
attention.
I don't pay any attention to the estimated A1C.
Or is
Absolutely.
it that this estimated HbA1c could predict what the HbA1c could be 3 months later or 6 months later?
It doesn't happen all the time, absolutely. It is just something that these modelers and mathematicians have imposed on us,
It's the least important
It's
thing
the
to
least
do.
important part of it.
Yeah.
And as I said, I think in 10 or 15 years, A1C will be a thing of the past, because A1C doesn't tell you anything about glucose variability or stability. Zero, no information. Yeah. Let's move on. Yeah, let's move on. Again, for the interest of time, let's
show you what happened. Next.
Yes. What happened here? Adjusted basal.
Adjusted the basal bolus. Yeah.
Okay. And the CGM patterns are a lot better. Again, forget about hemoglobin A1C. Oh, this is another.
Go to the next one.
It's not going. Okay. Now, patient went on a holiday in southern Spain. Did not adjust insulin despite change in diet and exercise. Again, this is reality. This is what happens. You stabilize a patient doing perfectly well in Pune. As soon as he goes to Darjeeling or somewhere else, all hell breaks loose. So again, you know, these things are important, and it will help in educating these patients about behaviors and things like that. So everything goes out the window as the patient goes on a holiday. There's no hypo, of course.
It's all hyper.
It's all hyper, you know, a lot of food, a lot of pizza or what have you, you know. So, oh, Spain, no pizza, yes. Spain, there's a lot of tapas, yes, and wine maybe. Okay, so intervention, they reinforced the current regimen, and things got better again. The lesson is that, you know, you should not discourage patients from going on holiday. That is certainly, you know, that's not the reason for this. And again, if you ask me, you know, having hyperglycemia for a short duration of time probably doesn't matter. You know, the patient is a human being. We are all human beings. Let him or her indulge for a short duration of time, as long as it's for a short duration of time, you know. And then once the patient gets back, things will improve. Another patient, Matilda, 66-year-old female with type 2 diabetes for 11 years, takes twice daily premixed insulin plus metformin. Last hemoglobin A1C 8.5%, weight is rising, needs hip surgery, occasional hypos, mainly on waking, but also at other times. AGP was undertaken as surgery was cancelled following an arrival at hospital with unacceptably high blood glucose levels. So, elective surgery, this is the CGM. How would you interpret? I see Dr. Jyoti Dev is here. He is going to volunteer right now. No, I'm sorry to pick on you. Up to you.
There is, obviously, there is glucose instability.
Right.
So there is an area of a possible hypoglycemia that is early in the morning.
Right.
And of course, there is huge glucose variability all across. And maybe some 25% of the time, there is hyperglycemia. So you need to change the regimen to a basal bolus, preferably.
Okay, yeah. I would agree 100%. You know, this premixed insulin is not a good insulin unless the patient cannot afford the MDI. So what did this doctor do? So diagnosis, significant variability due to insulin action, dose timing, etc. Strategy, drop premixed insulin and start basal insulin with evening meal. At least this is what the doctor did. It's not me. This is what the doctor did. Start GLP-1 receptor agonist once weekly with dietary counseling. Let's see what happened next. Okay, things are better. So the glucose variability settled down quite a bit. There is less or no nighttime hypoglycemia anymore, but there's still some daytime hyperglycemia. So let's see what the doctor did. Oh, I think the doctor stopped because the patient was better, so the patient went for surgery. Okay? So here we have Mr. Ahmed, 55-year-old male taxi driver. This is obviously in the US. The word male is redundant. Works night shifts with type 2 diabetes for 8.5 years. BMI 31, A1C 9.5%. Treated with metformin, sitagliptin, and low-dose sulfonylurea. Refuses to consider insulin or any medication that would cause polyuria, understandably because the patient is a taxi driver. And refuses also insulin because of fear of losing their license, you know, for a taxi driver. Infrequent SMBG, no meal pattern. This is a difficult situation. Any volunteers? How would you manage such a patient? Now, is insulin use a contraindication here for taxi drivers and stuff? I don't know.
There is no regulation. We don't know whether the taxi driver or the PMT bus driver is diabetic, what medication is he taking.
Okay. So this is reality. This is reality. Yes.
In the US, they will lose their license, yeah. Okay.
So let's see. I don't know what they did. Let us see what they
This is
did.
not us.
There's someone else.
Somebody did something. We're taking
Halt sulfonylureas replace DPP4 agonist inhibitor with GLP-1 receptor agonist. Okay, what happened next? All right, this is what happened. So the variability improved, the median glucose also improved. Forget A1C, and no hypoglycemia. Okay, but still significant nocturnal hyperglycemia. What happened next? Again, this doctor is working with the patient to help him understand his diabetes better and hopefully improve. So, the patient consented in taking low-dose basal insulin 6 units twice daily and titrate over the next 6 months to 24 units. Look at that. Perfect. So, although the patient is reluctant, etc., with showing him the CGM would hopefully improve the understanding. And I don't know what happened to his taxi license here, but certainly overall his glucose control was a lot better. I think in the interest of time, we can stop here, and because there are, I think, 1 or 2 more examples that we can go over, but in the interest of time, I want to keep to time. If there are any questions, we would be happy to answer. Again, we just wanted to show that how we can use CGM. In the US, in certain states, there are some legal issues involved that, these patients will need a doctor's certificate every few months to make sure that they're not getting hypoglycemia while driving. That's an important thing, is try and prevent hypoglycemia during driving, because then you're not only exposing yourself, but other road users if you have an accident. And
Excuse me?
I over the last 25 years and 30 years, I've had 2 of my patients die because of hypoglycemic accidents, during driving. So it is safety.
So how did this taxi driver afford GLP-1 RA?
That's a good question. Again, GLP-1 receptor agonist, depending on the patient's insurance, will be covered. Certain GLP-1s, yes, may not be every GLP-1, but certainly, certain GLP-1s, depending on the insurance. And that's a game that we have to play in the U.S. Because each person's insurance may be different, so it's a very tedious game, but it has to be done. We are hoping to streamline it and make it more user-friendly for providers and for patients. Again, one of the other realities that I want to briefly discuss is that even if the insurance company approves the use of a CGM, for example, after I write the prescription, sometimes it takes up to 2 months for these patients to actually get a CGM. So it is a disaster sometimes, especially in certain parts of the country. When we were at Mayo Clinic up in Minnesota, things were far better, far quicker, because Mayo Clinic, being one of the premier institutions, has clout, has name, has power. University of Virginia, although it's a good institution, and the Center of Diabetes Technology is known throughout the US, it takes time. And certain parts of rural Virginia, I will tell you, is more deprived than areas of rural Maharashtra. No question. I've seen that. I've seen that happen, that certain parts of rural Virginia is worse than
I would just
rural
like to
Maharashtra.
comment on the taxi driver, that even in India, our drivers, our shift workers are usually not very affording. But if you convince them, and if you use this at least to showcase their patents and use a basal insulin or whatever is affordable by seeing the variability, they do get convinced, and it's worthwhile to spend that much money once or twice,
Right.
versus the number of hypoglycemias and work-related dropouts they get in their different shifts and hospitalization. So often we are able to achieve
Right.
that even
Yes.
with the not so affordable
No, absolutely,
people.
absolutely. Yep. Yes, sir.
Sensors which require calibration. So when a patient is using a real-time CGM and is going to calibrate, so patient sees a variation between the finger stick value and the real-time CGM value, what the patient is seeing. So what you suggest, if the discrepancy is too high, should they calibrate, not calibrate? And if they are on drugs, like let's say paracetamol, so what are the recommendations?
Those are good questions. You know, as you know, the newer CGMs that have come out are factory calibrated. They do not need calibration. But people who are using older CGMs, you know, older models of CGM, older versions of CGM, the best time to calibrate that we tell them is when their glucoses are the most stable. That is before a meal, after an overnight fast, before breakfast. That maybe would be the best time to calibrate, or before the evening meal. So when the glucoses are not changing that much, you know, then that would be the best time to calibrate. If they try and calibrate after a meal, there will be a problem. But these newer sensors don't require calibration. I don't know whether, you know, the Abbott Libre doesn't require calibration. Dexcom has not come here yet, or not the newer
It is
version.
there, but not so commonly used.
Garden Connect, yes. So as far as the medication question is concerned, ideally you need to calibrate when he is not taking the medications. And again, we do not know, you know, the data that Rita showed was after a single dose of these medications, of Tylenol. With repeated dosing, we don't know what the problem is. Those studies will need to be done. Yeah.
One quick comment and one quick question. So we are all very proud of you both. Originally from India.
Give them a
Ananda
big
Basu and
hand.
Rita Basu.
Really.
Originally from
The
India.
couple has done.
Globally well-known personalities, and they are international speakers and
Absolutely.
international
Yeah.
researchers. Very, very proud of you.
Vande Mataram.
Very audience friendly, frankly.
Yeah, absolutely, absolutely. So, one.
Sorry?
Are you missing mayo?
Some part of it.
And
Some part of it,
mayonnaise.
but not all. You know, Minnesota, you know, if you know the temperature,
Minus 70
was
degrees,
minus
we do
70.
not miss. No.
That is something I do not miss. इस बुढ़ापे में नहीं भाई, वो नहीं चलेगा. Yes.
And you remember I landed there in December.
Sorry?
I landed there first time in December.
Exactly. Yes, exactly.
We
exactly.
do that, you know, we do that, Jyoti Dev, to all the good friends we have.
Yes.
We invite them in the middle of winter. That's what we do.
That means they are true friends. They are true friends. Yes.
No, one quick question.
Yes, yes, please.
Because in India, we rarely come across allergies, skin allergies when we put this Libre. Have you ever come across in US?
Yes.
Yes.
And then we try and change the adhesives and so on and so forth.
Can you change adhesive for a Libre or Libre Pro?
No, we don't.
There's
So,
only-
you know,
yeah.
in those patients, it is difficult, no question. It is difficult.
Thank you.
You know, we have used local steroids sometimes, you know, it doesn't really help much. You know, it is difficult, but thankfully uncommon problem.
Uncommon, because once they have a allergy, then the second or the third time it is more generalized
yes.
and more severe.
Yes, yes.
And you know, the other thing which I'm sure you guys also see here, that we see is, it falls off also.
Yes.
They lose their sensor very easily sometimes. Even though we apply it and we explain to them how to use it, whatever, but they try to wear clothes or they're rubbing with a towel or something, so they lose their sensors a lot. So you have to keep replacing.
Or they're exercising, sweating, things come
Something,
out.
you know,
Yeah.
it
So
comes
these are
out. So,
practical
yeah.
solutions that hopefully the sensor companies are working on to try and improve.
Well, rest of the questions we can ask them in person. But it was in a very fantastic presentation by Basu couples. Let's give them a big hand.
Thank you, thank you.
Absolutely fantastic. Very friendly.
Jai Hind. Yes,
Jai Hind.
thank you.
The workshop has been very, very successful, I would say.